Hello.
Yeah, yeah.
Good
One
afternoon, sir.
second. Monica, you want to start now? Okay.
Yes, sir. If my
Okay. So
screen
I
is
would just request everyone to mute your uh, sound right now and videos. Once Monica finishes presenting her paper, then we'll have a discussion. Okay. All right. Please start.
good afternoon, everyone. I'm presenting one article which is detailing about the studying hypothesis. Hello. पंद्रह बीस मिनट बात कर लो ना प्लीज.
Yeah, Monica ji, please start. Yeah, continue, please.
Yes, sir. Good afternoon, everyone. I'm presenting one article relating to the study or the hypothesis stating the crouch gait by the development of spastic diplegia, which can be prevented. Aim of the study to determine whether a change in surgical management of the equinus gait decreases the prevalence of severe crouch gait, and if there any association between prevalence of severe crouch gait and the orthopedic practices. The three methods of equinus gait correction are studied, in which stairs, the gastrocnemius recession, Baker's gastrosoleus recession, and Hoek's lengthening of tendo-Achilles were discussed and studied for further 15 years. Patients and methods. This is a retrospective analysis of a 464 patient, in which 27 with the crouch gait were studies, where the crouch gait are studied in sagittal kinematics, and patient were in age of 16 to 18 years. Inclusion criteria: GMFCS 2 and 3, and they were studied in 3D gait analysis. Sagittal kinematics shows crouch gait. The age of the patients in the group of 6 to 18 years at the time of gait analysis. The gastrocnemius recession described by Strayers was modified. It was separated from the soleus fascia, and transversely upon analysis was divided and checked for dorsiflexion. Only if not satisfactory, then soleus fascia was also transected. In results, out of 27 cases, 17 cases had lengthening of the gastrosoleus, with a mean interval between operation and development of a symptomatic crouch gait was 6 years. The 9 children had bilateral Hoek's lengthening of the tendo-Achilles, and 8 children had bilateral Baker's type of lengthening. After using Strayer's method, number of cases developing crouch gait reduced from 25 to 0.4%. The study started from 1994, and the TA lengthening for all the three types were studied, in which at the starting Baker's type of gastrosoleus recession and Hoek's TL tendon lengthening was used to applied, which eventually converted to Strayer's gastrocnemius resection because of less development of crouch gait. Following introduction of single event multi-level surgery, solid AFOs were prescribed routinely for minimum of 12 months post-operatively. In single level gastrosoleus lengthening for equinus gait resulted in calcaneus at the ankle in 36% at 5 to 10 year of follow-up. This was disabling crouch gait because of loss of effective plantar flexion, knee extension coupling. Development of crouch gait was rapid at age of growth spurt. In patient who required crouch correction surgery, the period from surgery from equinus can be so long that neither the patient nor surgeon may consider the obvious connection. Only long-term study using objective outcome measure could identify the insidious problem of over-lengthening and crouch gait. The changes in management of equinus gait from 1990 to 1994. changed towards further gait analysis. Observational gait analysis improved towards 3D 3 dimensional gait analysis, and spastic equinus, which was treated before with a serial casting, it's converted to injection of botulinum toxin A. Orthopedic surgery, which was previously done as single level surgery, which is improved towards single event multi level surgeries. Equinus surgery, which was done previously with the Baker's gastrosoleus resection and lengthening of tendon Achilles tendon, which is improved towards stress gastrocnemius recession. Rehabilitation of with ankle foot arthrosis, post-operative monitoring, which was usually previously done hospital-based hinge outpatient clinic, which is converted towards gait laboratory and solid DGA. The high prevalence of severe crouch gait during the first 5 years from 1995 to 2000 was mostly iatrogenic with single level surgery by lengthening of tendo Achilles. There were no cases of severe crouch gait following stress recession performed as a part of a single event multi level surgery. The limitations of the surgery are the lack of detailed data about ancillary factors, which are post-operative rehabilitation, the prescription of AFO and post-operative monitoring, the changes in management of equinus, the lack of gait study in entire population, the exclusion of a milder form of the crouch gait. The patient who had no previous lengthening of gastrosoleus had severe liver arm diseases, increased femoral neck anteversion, patellar alta, external tibial torsion, and pes valgus. The strength of the study is population-based study, used a valid and reliable description of the severe crouch gait, sufficient duration to detect changes in surgical practices and gait pattern. Hello? Hello?
Yes, yes.
This is
Continue.
open for discussion. I just want to just summarize what Monica has sort of listed here. One is that what they studied was till 95 they were doing uh, Baker surgery. After that they changed, and what we can see here, the change in incidence of crouch didn't follow immediately. It came after 2000, because what surgery you do at ankle today, it reflects in crouch after 5 years, not immediately. So it has a effect after 5 years. So that is what is seen. What is surprising is that out of 27 crouch, only 17 had TL lengthening. Not everybody had TL lengthening. So and so those 10 patients who did not have TL lengthening also developed crouch, and this was associated with severe liver arm problem. But at the same time, what I wonder is they have not told about all patients who had TL lengthening. See, out of patients, total number of patients who had calf lengthening, how many have developed crouch and how many did not develop crouch is not mentioned in this paper. So that's something which I feel is a data which has been concealed or not been looked. Any other sort of uh, outcomes? Anyone wants to discuss anything from this paper? Avi, you want to say something? Just
Uh,
unmute and discuss. Yeah.
yeah. So most of the points you have already highlighted. Anyways, we need to remember the growth curves. So all of our crouch comes in the older age, anyways, not in the earlier age. So by the time we see the effect of most of our surgeries, it will take some time to see when the child comes in crouch. And also there are other factors such as the weight, the muscle power, and other factors which lead to crouch as well, other than the surgery, which we haven't got because they haven't analyzed the separate group. So more study is required to know these kind of subgroups which actually lead to crouch.
Right. So everyone can start their videos if not, because this is not a webinar, it's a discussion, and every point of view is important here. So what I would request is when somebody is presenting, we'll mute our microphones, but once we start discussion, you can unmute and again mute when someone starts presenting. So if anyone has any other point of view, any questions from fellows or residents, has everyone understood outcome of this paper? So if we have to really, uh, see how this paper can apply to our situation, one thing we have to realize is there are three takeaway points. One is that don't do TA lengthening and don't do Baker's procedure. Baker's procedure was one in which you used to make a sleeve like this, and then do and slide it. We have also done many of them in past, and I learned it. Actually, I saw Dr. Jory doing it, and we used to do it. But Baker's, they say, is associated with a lot of crouch. Second thing, what we have learned is even if you don't do TL lengthening, but if you have effective soleal weakness because of liver arm disorder, that can also give rise to crouch. Third thing is what they said is, this was an era between 95 and after 95. And it was not just the method of TL lengthening. If you see the graphs, the number of calf lengthening have not reduced. They have remained the same, but the crouch has reduced. And this could be also because they did multi-level surgery. So if they did calf, they did hamstring along with it, not just isolated calf lengthening. So we don't know if that was associated with reduction in incidence of crouch. So a lot of things happen together, but it's important to take away a message from here that TA lengthening and Baker's lengthening both should be avoided. It should be judicious, and you should delay the surgery as much as possible. And lastly, if you are doing TA lengthening, you should watch that patient at least for 5 to 6 years so that you can see if your patient has developed crouch or not. All right. Anything else, or shall we go on to the next paper? Just show me thumbs up so I know that all of you want to go to the next paper. Okay. All right. Okay, Monica. Next one. Quick.
Yes, sir. The next paper is related to the biomechanics of the crouch. In this,
Yes.
the aim of the study was to determine how crouch posture affect the capacity of muscle to extend the hip and knee joint during the single limb stance phase of the gait. This is the model of the crouch which they had studied uh, in 3D analysis. In crouch gait, the patient will have reduced movement generating capacity of the hip and knee extensors as a result of skeletal deformity, impaired motor control, muscle atrophy, and muscle operate in suboptimal region of their force length curves. The material and methods inclusion criteria for this study was walk with crouch gait. The patient will have knee flexion angle of at least 20° at initial contact and greater than 15° throughout the stance phase, which is approximately 2 standard deviation above normal. An exclusion criteria is equinus gait. The crouch gait is grouped according to severity of the flexion of knee. Mild between 20 to 30° of knee flexion at the initial contact. Moderate crouch is subject between 30 to 40°. Severe crouch subject to more than 40°. And 83 independently walking patient with crouch gait have been selected for this study. The crouch posture reduces the capacity of the muscle to extend the hip or knee joint. Individual required to exert more muscle force to maintain a crouch posture. It alters the acceleration of the hip and knee joints that are induced by gravity, further increasing muscle force requirement. In this study, the models were prepared which which were studied in acceleration analysis and muscle force and the gravity force were studied to quantify the effect of crouch gait on the extension capacity of the muscle and action of the gravity at the hip and knee, and induced acceleration analysis was used for each muscle path in the model. At every 2% of the single limb stance, 1 newton muscle force and corresponding ground reaction force were applied to the model in isolation. The resulting angular acceleration of the hip and knee joint were then calculated using the model equation of the motion. These acceleration represent the capacity of each muscle to extend the hip and knee joint per unit force for each position of the single limb stand. To determine the hip and knee angular acceleration induced by gravity throughout the single limb stance, a gravitational force to the center of the mass of each model segment was applied, along with the corresponding ground reaction force at the foot. The results were in crouch gait, the larger hip flexion and internal rotation than the normal gait when averaged over the gait cycle. The pelvic tilt will be more anteriorly in all the kind of crouch uh, compared to posterior. The hip flexion will be more anteriorly, and the foot progression angle also will be deviated towards the external side. The each crouch group also has larger hip flexion and internal rotation than the normal. The gluteus maximus, posterior gluteus medius, and vestibular soleus all had substantial capacity to extend the hip and knee joint. During normal single limb stance, capacity of all these muscles were reduced more than 50% of their original capacity. At the hip joint, crouch gait had little effect on the psoas but increased the capacity of the rectus femoris and tensor fasciae lata to generate flexion acceleration at the hip joint. At the knee joint, the tensor fasciae lata showed a slight increase in flexion capacity with crouch gait, while the psoas showed a decrease in the flexion capacity. In normal gait, we'll compare the gravity accelerated the hip towards the flexion in the first half of the single limb stance and towards the extension to the second half. The gravity acted to flex the knee throughout the normal single limb stance with a decreasing magnitude as the stance progressed. In crouch gait, gravity instead had a flexion action at both joints throughout single limb stance, increased demands of the muscle, which causes increased energy to the muscle. Reduction in average muscle extension capacity during single limb stance as a result of tibial torsion compared this result to the trend observed in the normal gait. Tibial torsion had a similar effect for both normal and moderate crouch gait, reducing the hip and knee extension acceleration generated by several important stance phase, gluteal muscle and soleus. The limitation of this study are single limb stance phase of gait, since obtaining a continuous estimate of the ground reaction force component of for each muscle required that the foot had a zero acceleration. That is, it was rigid contact with the ground. The single limb support phase is of a particular clinical importance, since the generation of the excess knee flexion accelerations during single support is thought to be one of the major contribution in the crouch gait. Excess of tibial torsion, a common skeletal deformity in patients with crouch gait, reduces the capacity of the soleus and gluteus muscle to extend the hip and knee at body position corresponding to the single limb stance phase in normal gait. The negative impact of the crouch gait increases with worsening crouch severity, which suggests that crouch gait is a downward cycle. If correcting the patient's tibial alignment leads to small improvement in muscle to extend the joint, it leads a more erect posture and thus further improvement in muscle extension capacity. That is how reversing the downward cycle. The take home messages are: the dynamic analysis used in the study could be adapted to analyze the gait kinematic and bone geometry of the individual patient. Small improvement in gait posture as a result of physical therapy or surgery may help to reverse the process of worsening the crouch. Thank you.
Right. So, I will just summarize again what this paper means. Is what they have done is it's not actual study. What they have done is taken data from patients who had normal, then who had mild, moderate, and severe crouch. And from these data of the angles and ground reaction forces, they made a mechanical model. So the mechanical model is a computer generated model. It's studied in the lab. And to this model, what they do is they apply forces, say gravity force, a simulation of gravity force. And then they felt that with gravity, the knee flexion and hip flexion worsen. Then second thing they studied was the effect of this positions on the muscle strength. And they said that whenever you have these crouch kinematics, the ability of knee extensor, which is quadriceps, and hip extensor, which is gluteus, the strength further reduces. And third thing they said that if there is tibial external rotation, which is a lever arm problem, that further reduces the strength of soleus and gluteus. So hence that will potentiate the crouch further. And as a sort of inference, they say that if you are able to correct the tibial torsion, that will improve the crouch. If you are able to change the angle, the tibia going forward and knee flexion occurring in stance phase by using an A4 that will sort of reduce the crouch, or strengthening the muscles will reduce the crouch. So this is a biomechanical paper which is suggesting what can be done to treat a mild crouch. So now, so this is what is, changing the philosophy. Now we started with prevention, okay, of a crouch by not doing tail lengthening, and this is the second paper which tells us that if you have a crouch and don't treat it early, it will go for rapid progression. So you moment to detect crouch, you have to put certain actions in place. So that's what he says. Any questions or comments? Has anyone read this paper? It's very confusing and very boring paper to read. But once I think now, if you go and read it back with this sort of introduction, it will become more interesting. Samir, you want to say something, because Samir is going to present tomorrow's POSI webinar. Yeah.
No, actually, a very important point that they have brought out about tibial torsion. Actually, we are
Yes.
focusing so much on excessive femoral anteversion that we
Absolutely.
are forgetting to derotate the tibias.
Right.
So I think so. We should also look at the tibias, which is going to help in the power of soleus and gastro.
Right. Right. And what they say is it's not just about soleus. Change in tibial torsion also improves gluteal power. So what you do to the foot or tibia also affects the hip and then the spine. So it's a chain reaction which is going to go on. Any other question? If everyone is okay, Avi, anyone else wants to? Who else is there? Jaideep, you want to say something? Okay. Shall we go to next paper?
Yes, sir.
All right. So who's the next one? No? Share your screen. I think it's Gurinder Singh, and he's going to talk on natural history of crouch gait, and then on use of floor action orthosis in patients with cerebral palsy. So Gurinder is a fellow at SRCC. He is from Jalandhar, and we have to really thank him because he has held the fort of SRCC in times of COVID. He's there working every day and helping all the consultants. Yeah. I'm happy you found time to review this.
Am I audible?
Yes, very much. Yeah. Just do full screen.
Yes, sir. Okay, can I start?
Yeah, please.
The study, Natural History of Crouch Gait in Bilateral Cerebral Palsy. It's a systemic review. So aim of this is to systematically review the natural history of crouch gait in bilateral cerebral palsy in the absence of surgical intervention, and to review any relationship between clinical variables and progression of knee crouch. So introduction to study is like I want to say that all participants were diagnosed with bilateral CP and were able to complete a gait analysis and were therefore able to ambulate. Their systemic review suggests that in the absence of surgical intervention, the natural history of crouch gait is towards increasing knee flexion over time. The rate of progression of crouch gait appears to increase in those with knee flexion greater than 20 degrees during gait, which suggests that this might be an indicator of more urgent intervention. So coming directly to the discussion that this is a consistent with the finding that not all those who walk in crouch have short hamstring and suggests that hamstring tighten over time in response to walking in crouch instead of a causative factor basically. The recent systemic review reported that hamstring surgery is an only intervention for crouch for which substantial evidence exists and highlighted the need for further research on interventions beyond the hamstring lengthening and also needs the prospective study on crouch to examine what are the multifactorial contributors to this gait pattern. So, conclusion of this study is there appears to be two patterns of increasing crouch. The first is gradual increase in knee flexion over time, which may not require surgical intervention. The second pattern is of more significant comparatively, which include rapid deterioration, which might be prevented with appropriately timed orthopedic intervention. Knee flexion in stance appears to be best differentiate these two groups with values of 20 degree or more of particular concern. and a potential disruption. I repeat, potential disruption of knee extensor mechanism should be investigated. Increasing clinical measures of hamstring tightness appears to occur over the time secondary to knee flexion rather than causing it. Okay, thank you. That was a conclusion.
Thanks. Yeah. So let's have discussion on this. Anyone, any viewpoints here? So two very, take-home messages from here. One is that hamstring shortening may not be cause of crouch. It can be effect of crouch. That is what this review suggests, a natural history. And secondly, it suggests that there are two patterns. There are some children with crouch which will rapidly progress, some will slowly progress. And third point I got from this paper is that knee flexion deformity is not important, but it is the knee flexion in stance phase, in mid stance. If it's more than 20 degrees, that will lead to very rapidly increasing crouch. That is very important, because knee flexion deformity we measure in lying down position. The knee flexion in stance phase is measured on an analysis. But if you want to measure it, what you should do is just take a video of the child and freeze frame at the mid stance phase, and then you can measure the knee flexion. And everyone can do it with a small mobile camera. Yeah. Any questions? Any other sort of outcomes from this paper? Observations?
Sir, in this paper, hello.
Hello. Rohan.
Sir,
Yeah. So Rohan is saying that other factors like age and weight are also important, and that's absolutely true. Weight and obesity, they are important contributors to crouch. Samir, anything on that? Effect of body mass and obesity on crouch. Have you come across that?
Yeah, I'm sure there must be a paper on weight and body mass index on crouch. But a very important thing that which I wanted to point out is that there is this crouch terminology called crouch surveillance, which they have now introduced just like hip surveillance. And
Okay.
looking at the actual degree that we have found out, 20, what is mentioned in this paper, that more than 20 degrees of knee flexion in stance has an increased risk of crouch. Probably a child which has more than 20 degrees of knee flexion should be included like in a high risk group, and he should be followed up more frequently, just like they do for hip surveillance.
More than popliteal angle and knee flexion deformity, this knee flexion stance. I think Chasnal is there. I just want to ask Chasnal, from the study which you did, did knee flexion and stance and knee flexion deformity or hamstring shortening, did they have a correlation in your paper, or you think it's independent?
Knee flexion in stance, sir, and knee flexion
And knee flexion deformity, are they correlated?
No,
or
sir.
different?
If there are weakness, sir, then in the upright position, the knee flexion is much more in mid stance. While in the supine position, the patient may have less knee FFD. So I think even apart from the fixed flexion deformity, the weakness is also playing in, just like the patient sinking in the crouch.
There are multiple factors which play in crouch. Knee flexion deformity is not the only factor. Hamstring tightness is also not the only factor. What really, it's an interplay between knee flexion and knee extensors, how they are acting. And it's also interplay between hip extensors, position of the knee, and ankle plantar flexors. And all these things are together manifested in knee flexion in stance phase, mid stance. It's not just one factor. So that I also feel that is much more important than knee flexion deformity. Many times your knee flexion deformity may not be much, but patient may still have crouch, or hamstring may not be tight and patient may still have crouch.
So I had another thing. Most of the studies have never taken into consideration the motor involvement of that child. They consider GMFCS, but
Yes.
the amount of motor involvement and power plays a big role.
So you meaning selective motor control or strength?
Strength. Strength and
Right.
selective motor as well, but strength more so.
Right. So are there papers, Samir? Have you reviewed this? Anything which compares strength and crouch development? किधर कुछ correlation है?
Yeah, unfortunately, I have not read a paper on that, but I'm sure there must be. Probably we can search for it.
Anyone else? Chastal, do you any
Yes, I think
correlation where people have?
calculate like evaluating the MMC or the muscle strength in presence of spasticity is quite difficult. So probably that's why most of the papers they can't quantify it. Probably that is what I think one of the reasons.
An extension lag is again, it talks more about looseness of quadriceps than the strength.
Mm.
So,
And again, so if the hamstrings are short, then it might look like a false extension lag also,
right, right.
which are actually because of the
Because
hamstring contraction.
we do it in sitting position. But
So
but
again,
some important takeaways, is that knee flexion in stance is important, and hamstring may not be short. It may be secondary.
yeah, yes.
Any other comments, or otherwise we can move to the next one? Can we? All right, Gurinder, yeah, your next paper. Share the screen again. So please feel free to ask questions. This is not like a webinar. Be active, and as we have it week after week, if it's possible, study, read all the papers and come, so that we can actually contribute. Yes.
Okay, am I audible?
Yes.
Okay, this study includes that the use of anterior floor reaction orthosis in patient with cerebral palsy. So in this picture, we can clearly make out a ground reaction force in normal child as well as spastic diplegic child. So with the if ground reaction force correction, we can easily do with the simple AFOs or KFOs. In addition to rigid immobilization of ankle mortise, enables the transference of flow reaction to the front of knee. So why coming next to anterior floor reaction orthosis? The good thing I want to add in this that we can mold this orthosis with the help of plaster of Paris cast, because what I think every child with the crouch or with the CP with the crouch is a different. So we can mold basis on the requirement of the child. So to understand this anterior floor reaction orthosis, first I want to tell you little about the biomechanics of this orthosis. So in first picture you can see that if we keep the foot in 5-degree plantar flexion, so this is the knee extension movement. The more plantar flexion ankle is set in, the greater the knee extension movement will be there. If we keep the foot in neutral position, there will be the reduction of D1. What D1 is the distance? This is the D1 distance between the knee and the ground reaction force. And last picture, third, we don't want this because this ground reaction force is going little behind the knee, which shows that 15 degree of dorsiflexion. So in this picture, we can see the left and right. In left picture, there is a child walking with the help of crutches or a forearm guards without AFO application. And in right picture, we can clearly see this anterior floor reaction orthosis. In right picture, we can assess that forearm guards are just for the balance comparatively to the left picture. So it helps in better ambulation as compared to any other or without any orthosis. So results or conclusions, we can say single support time improved with orthosis, stride length and walking velocity will be improved. Energy consumption remain unchanged. And but there are prerequisites for this orthosis to be used. Absence of knee or hip flexion contractures exceeding 10 degrees. Careful determination of the angle to which the ankle mortise is set within the orthosis in order to optimize forward progression of the weight line at mid stance, while still maintaining an adequate knee extension movement. Presence of some trunk balance or the ability to use auxiliary walking aids in the event of diminished trunk balance. Presence of minimum grade 3 quadriceps strength is required for this orthosis to be used. Okay, thank you.
Right, right. So these prerequisites are like Times of India matrimonial column. You can never fulfill them. So all our crouches have knee flexion deformity more than 10 degrees or a hip flexion deformity. And our body mass, you require body weight of minimum 40 kilo before you can apply FRO. And our patients are thin and lean, and they will not have quadricep power more than 3 plus. So a lot of ifs and buts. But what has been experience of people using FRO or a solid AFO in management of crouch? How does it work? I use it as a post-op for people, patients who are weak, and it allows you to stabilize the foot and control the knee at the same time in the recuperating phase after surgery, where the power of quadricep is still weak. So it helps them. But I don't know how much do we use. Are the people who are making good FROs? So I want to ask Samir first, and then Avi, Chasnal, Chaideep can
Yeah,
come.
to tell you the truth, if we need an FRO, we always send them to Bombay. There are one or two good people who make FROs. Uh, it is a little bit difficult because the children are heavy. So the second most important thing that in this paper is the prerequisite about that knee FFD, and as Taral sir said, he uses it in a post-surgery patient. So the prerequisite is that the child should have less than 10 degrees of knee FFD. So if he has more knee FFD, then if you give this, then the child is likely to worsen. So having a good FRO post-surgery is very important.
Or this can be useful in a situation where you've done a hamstring botox or lengthening and given a stretch cast and got the knee deformity corrected, and then you want that patient to walk. FRO can be really useful. Chasnal, what's your viewpoint? What do you feel about use of FRO? Is she online?
She's muted.
Net connection
Hello.
is.
Yeah, sir. The same view, sir, as you said. Like probably the residual mild knee FFD could be corrected with the FRO, sir.
Mm-hmm.
So,
Children also get a lot of anterior knee pain with FRO if their knee flexion deformity.
So other thing, when I read this article, I tried and see few others. There's quite a bit about debate of do they give or do they not debate, because most patients, at least in our scenario, never fit into the criteria they give. These are all patients who are under constant monitoring with gait abroad, where they find mild crouch and they put them in FROs early to prevent the deformities. And lot of them say that you have to be really selective, because they say like it works more in patients who have a slower velocity, weak plantar flexors, and extensive external foot progression. It helps them more compared to the other children who are
Right.
of more higher functioning.
Mm-hmm. Right. Patients who are slow and have a lot of rotational problems, it will help them to
Adjust more. The high functioning ones, it's more like post-op we are giving up salt for those kind of things than pre-surgery.
Right. So one more thing issue was most of these FROs designed which are described abroad are rear entry. So your foot enters from behind. So there is a hole posteriorly, but most of our orthoticians convert an AFO into FRO. So that really doesn't work that well. You need a rear entry FRO so that the ankle 10-degree equinus can be maintained. With a regular AFO which is converted into AFRO, you cannot maintain that equinus or a plantar flexion knee extension coupler. But if someone can make a hydraulic kind of a hinge or a force, like a spring action FRO, then that might work better. Something which can give rise to plantar flexion force and pull the tibia behind, like how soleus does. If that can be caused, with a small spring or a battery, that can work well. I think Pankaj Sinha was trying to make one like that. I don't really know what happened. Yeah. The
That
problem is his cost of. I should not mention we are recording this, but I'll edit this. His cost of FRO is more than cost of surgeries.
Taral, there is a nice splint being made in IIT by
Okay.
one of patients. I was part of the project,
Yeah,
and
I
they have
saw that.
got a very big grant from Delhi
Yes.
to
Right.
start the company and make that. So it's as you mentioned, hinges which will actually try to push the knee back.
Hmm. So
So
that
let's hope.
is about unlocking and locking the knee joint, right?
Yes, yes,
So when the foot is off the ground, it's a HK. What Samir is talking about is KFO. So when foot is off the ground, it
it
unlocks. When the
unlocks.
foot
Yes,
goes on the ground and knee locks
correct.
automatically. Yeah, so I've seen that. Have you used it any of the patients, Samir?
No, no, they are still in research. I mean, they have not started mass production. Probably
Yeah.
in about 6 months' time, he's going to start making it.
No, he made it and showed it actually. I went to IIT and saw that. And you can cycle because the knee is off the ground and it unlocks. And the moment you
Correct.
put foot on the ground, it locks. That's the technique. Next paper, paper number 5. I think it's Varun.
Mine, sir.
Varun Shet, a fellow at Jupiter. He's MUHS fellow. So he's going to present next two papers. Yeah, please.
Good afternoon, everyone. So this will be the first paper which I'll be presenting. This is a paper from Germany. It was published in 2018. So it studies anterior distal femoral hemiepiphysiodesis to reduce fixed flexion deformity of the knee. And this is a retrospective study of 83 knees. So what they've done is they have retrospectively assessed all the cases with a fixed flexion deformity of more than 10 degrees. And this was over a period of 15 years. And they have used either 8 plates or staples for the procedure. And just going through the literature, actually what we see is that they have the largest case series available in literature. So 83 is the highest which we have seen in like all the studies. And they assessed the children clinically and radiographically every 6 months. And what they also told us that these cases were only of fixed flexion deformities, and they excluded all cases of dynamic flexion deformities, that is due to the spasticity of hamstrings. So in the study, there were 49 patients fitting into their inclusion criteria. So one of the primary point which they have included is that the children must have completed the entire treatment. That is, the implant has to be removed and the deformity has to be corrected. So only those patients were selected for the study. That's why they have these many numbers. That is 83 knees over the period of 15 years. And the average age of surgery, what they found was around 12 years, higher for males, lesser for females. And they divided the patients into 3 groups. One is based on the etiology, that is cerebral palsy, meningomyelocele, and like others which included congenital knee deformities, arthrogryposis, and 2 distal femur fractures. So this is one of the X-rays which they have shown in the paper. This is of a 10-year-old with meningomyelocele, and the patient had actually a inferior pole patella fracture prior to the surgery itself. So during the surgery, that was removed. Sorry, excised. And this is the final X-ray prior to implant removal. And what they found out was they had average follow-up of around 46 months, and preoperatively the flexion deformity was around 21 degrees, and this improved to around 8 degrees, the range being 0 to 50 degrees. And the mean correction rate was around 0.5 of 0.44 per month. uh, in these, again, they assess separately for the CP group, the meningomyelocele, and the other group. So CP group had actually the lowest correction rate, that is around 0.2 degrees per month. and the other group, that is those cases which had distal femur fracture and arthrogryposis, had the highest improvement rate, that is around 0.6 degrees per month. And the implant was removed at an average of around 32 months. Sorry. And what they saw was that the timing of surgery and correction, when they compared these two, so improvement decreased with the years of age. That is, when the primary surgery was done, if at all the child was of more than 10 years, they actually found that the improvement reduced with that. And at implant removal, the physis was open in 23 patients, and among these, 3 patients had recurrence. And in 8 patients, the fixed section deformity, it remained unchanged or actually increased. The maximum increase was around 10 degrees. And also implant loosening was seen in 10%, and 5% actually required reimplantation. So coming to the discussion, the procedure as such is a minor surgery, as in there is it can be done with a small incision, and there is no bony procedure involved in this as such. And the complications are also lower, and they didn't advise any immobilization following the surgery. They immediately started with knee range of movements. And as I told, this study actually has the largest data available in literature, and there are like very few other studies based on this. And what they've also told is, in those children who have poor bone quality, 8 plates would be better than the blunt staples. And they also segregated the etiology, that is for cerebral palsy and meningomyelocele and the others group. And as I already mentioned, this was what they actually found, that is the maximum correction was noted in the other group, and the cerebral palsy had actually very less correction as compared to the other 2 group. And early intervention is better, that is, if the surgery is done prior to the age of 10 years, it will be, the overall correction is much better. The limitation of the study is that it is a retrospective study, and they didn't have any control group. And one thing was, bone age is important for this procedure. So what they were also mentioned as a footnote is that they actually went according to the chronological age, and that might have been one of the cause that they had a few recurrences. So they tell that probably if we assess the bone age, it will be better in these cases. And also in this, the position of the patella and popliteal angle was not assessed in this particular study. So this is the first one.
So any comments now? I just want to share one of the papers. One second. So using staples or 8 plates to cause correction of knee flexion deformity is nowadays outdated. So this is a paper from JBJ SKS Connect, 2016, where they put wires and then percutaneously and then pass cannulated screws this way, and that results in correction of knee flexion deformity. So advantage of this method is that it is minimally invasive, and problems associated with plates and staples are absent here. We've also have one more modification of this technique, where we put guide wire from the articular surface coming out, and then put screws other way around. So anyone wants to comment on this?
Actually, this technique, we used to do it quite a bit in US and a little bit in Sheffield also when I was there. The plates used to cause a lot of anterior irritation and pain in the patients, with a lot of synovial effusion and synovitis. So it's caused a lot of problems. These screws do well, but again, the timing is very crucial. It may work, it may not work, all depends on the timing.
So one more issue is when you are doing anterior epiphyseal, it corrects the knee angle. But the problem is it also reduces the height of the anterior articular surface, which articulates with the patella. It makes it shorter. So there are going to be biomechanical implications of shortening anteriorly, because anteriorly there is articular surface. So we really don't know what will be the implications of that.
Yeah, we
Because
need,
surface area would reduce and pressures on knee might increase. We really
yeah.
don't know.
There are hardly any studies which compare the two methods, very few, as such, that I don't know of. I might have to look, that compare 8-plate and screw also, and there what effect do they cause in a growing knee to the groove and everything. There are no we need to study more to know about these things.
Yeah, Rohan wants to say something. Rohan, you can unmute and say.
Sir, that it's very difficult technically to put a screw anteriorly in the anterior hemiepiphyseal, putting it exactly there. So that's what I've done one case at that was what I took away from.
Right.
I'm still waiting to see how it works.
So tomorrow, if time permits, during POSI webinar, we might present a case, where we have done anterior epiphysodesis. We've done, in fact, number of them. Our strategy in early crouch has been to do very guarded hamstring lengthening, stretch cast, and anterior epiphysodesis. This is done at age which is 8 years, 9 years, where if you don't operate, the crouch will become more severe. And if you do a distal femoral osteotomy, it is not going to work because it's going to remodel. So growth is your enemy in these cases. But if you use growth as your friend and do epiphysodesis with hamstring lengthening, we've been able to get very good results in some of the patients. But we again need to see how long those results last, or what is functional change in the patient. Because many of the patients, we also observed that they do heavily rely on crutches or elbow crutches or walker, which they were not using earlier when they were actually walking with crouch. So I don't know, is that because of you're changing biomechanic in what way? What is happening there?
So when you did the procedure, did you have any consideration of the amount of deformity which was there, or it was just the age and that, like, what?
No amount of, so any crouch whether this mid stance knee flexion was more than 20 and knee flexion deformity was more than 30 degrees.
Okay.
Those were the patients we selected, because those are the patients which will which will have anterior knee pain. Many of these patients had patellar fractures, and we had to do something. But doing osteotomy was not right thing to do at age of 8 or 9 years. What are the other options? I don't know. If you have a 9-year-old with crouch, what else are you going to do?
Currently also, I don't think there are too many options. It's more of the old, everyone used to do the soft tissue releases and then stretch them, but
Yeah.
that versus the power reduction which happens in the muscles.
Absolutely. So let's ask Paulo tomorrow and take his opinion on this. Samir, what do you do for very young, children, pre-pubertal children who have crouch? What do you do? Samir hai kya?
Yeah, I'm there.
Hmm.
To tell you the truth, I have used 8 plates in CP, but then, as mentioned in a lot of papers, they cause a lot of irritation anteriorly. So, but unfortunately, I've been getting kids who are. Hello.
Screws are very smooth. They don't
Yes.
cause any irritation. They are much better.
Yes.
You should try using them.
I have not tried screws yet.
Hmm.
But unfortunately, we get these children at much later age. So at that age, epiphysiodesis is not going to help. We usually get older kids.
No. If they come at
I
age
would
where
definitely, yeah.
you will do osteotomy.
No, of course, epiphysiodesis.
Okay.
Sir, what
I
about
would.
capsular release?
So anything else? Otherwise, we go to the next paper.
Sir, what about capsular release in these
What about?
pre-pubertal? Capsular release, posterior knee capsule release.
posterior knee capsule release. Yeah, so I reserve them for patients who have very severe knee deformity. Say we've had patients who have 70 and 80-degree knee flexion deformity, where you cannot do uh, osteotomy, even hamstring lengthening will not work. So there, I have done a posterior knee release, get them straight, and then last 20 to 30 degree of deformity you correct with femoral osteotomy. So it's a doable procedure, but it has limited indications. Rohan, you wanted to ask anything? Any other
One
question?
more thing, sir. If we do these anterior epiphysiodesis in slightly older and heavier kids, or kids who have patella alta, or again who have extension lag, then probably later, once the knee FFD is corrected or the crouch is corrected, probably they'll still rely on a AFO or a flow reaction orthosis, or maybe they would need a PTA, a patellar tendon advancement again. So I think picking the child very early and younger age, a thinner child, less obese child, less degrees of deformity, and no patella alta, probably these could be much more helpful.
Yes. Actually, as you will come to some of the papers later on, we will review them. It has been found out, and it has been our experience also, is that uh, a crouch correction surgery makes a child with crouch to walk straighter, may not be necessarily better. So in terms of energy consumption, speed of walking, in terms of fatigue, it's not necessarily they become better than what they were earlier. And a lot of people are feeling now that, is femoral osteotomy the right thing to do? Though that's in fashion nowadays, we really don't know if that's the right thing to do.
So,
And that's yeah,
about what you're saying, I'll get to it in the paper in more detail, because the paper which I'm doing is exactly this. Yes. So, but to contrary to what you said, they do walk differently. They have improvements in oxygen consumption and certain things, but they don't have improvements as to ability wise. So
sorry.
yeah.
So the gait pattern improves and oxygen consumption improves, but the function doesn't change. Yeah. Is that so? We'll come to your paper and let's go through in detail at that point.
One last thing, sir. McCarthy has a very nice paper on the technique of this, the same way which you were describing, sir. We take it out from we put the wire from the joint. So in case, Rohan, you were having some difficulty with the procedure, so maybe you can refer to
We can share it on the group.
McCarthy's
And, I think
yes,
Tasa,
I'll put it
while
on
if
the
we
group.
have any old videos, no, which from our own thing, we can make a video and submit it as a video technique.
So maybe images can be converted and shared. So,
Yes.
I mean, image and make it a video of the images. Yes, possible.
Okay. Chal, next paper. Let's go. Varun.
Yes, sir. So this is a second paper. This is a paper from South Korea, published in the year 2017. So it is the factors influencing outcomes after medial hamstring lengthening with semitendinosus transfer in patients with CP. So there are actually many studies which have evaluated the functional outcome following distal hamstring lengthening, but the factors which actually influence this is not studied. So this study actually aims in studying that. So this was a retrospective study between 1995 to 2014, and they have selected all the ambulatory spastic diplegics, GMFCs 1 to 3, and they have done a preoperative and postoperative 3D gait analysis of the patients, and the what they also mentioned is that the post-op gait analysis was done as and when possible. So they have advised the parents to get it frequently, and those children who had extension osteotomy, they were excluded from the study. And all the patients, they underwent unilateral or bilateral distal hamstring lengthening, and this included graceless lengthening, and the semitendinosus tendon transfer was done to the adductor magnus, and also aponeurotic lengthening of the semimembranosus. And following the surgery, the patients were placed in a removable knee immobilizer, and patients who underwent TL lengthening or the bony surgery in the foot, they were put in the cast. And knee flexion at initial contact, the minimum knee flexion at the stance phase, knee range of movements, and the mean pelvic tilt and the GDI score was assessed. So what they have seen was they had actually nearly 594 limbs, and the maximum number of children were of GMFCS2. And the post-op gait analysis was performed at a mean of around 1.7 years. And after 2 years of surgery, the estimated knee flexion at the initial contact, it improved by 8.7 degrees. And the minimal knee flexion at the stance, it decreased by around 6 degrees in that is GMFCs 1 and 2. And in GMFCs 3, this was 8.1 and 5 degrees respectively. And in GMFCs 1 and 2, the knee range of movement, it improved by almost 7.4 degrees. And in GMFCs 3, it was 7.1. And the GDI score also improved in the first two, that is 1 and 2 by 9.9. And in the GMFCs 3, it was 10.4. What they have also seen was that the mean pelvic tilt actually did not significantly change, and the knee flexion at the initial contact, it improved greater in those who had femoral derotation osteotomy, and GDI score improvement was greater in those who underwent intramuscular psoas lengthening or femoral derotation osteotomy. And the increase in pelvic tilt was also less in those cases who underwent the psoas lengthening. And there was no significant annual change in the mean pelvic tilt or the knee flexion at the initial contact, even the minimum knee flexion in the stance phase, and also the knee range of movement. So the points of learning in this are that is the distal hamstring lengthening. It has been actually shown to reduce the stress on the knee joint and improve the stance stability in most of the studies. But again, in some of the studies, they have mentioned that it increases the anterior pelvic tilt and actually can eventually lead to a crouch gait. But in this particular study, they actually didn't. They showed that they didn't have any significant anterior tilt, and probably that is because of their the other procedure which they have done, that is that of the semitendinosus transfer. So the distal hamstring lengthening procedures in the other studies, so what we have seen is that they involved the medial hamstring lengthening, and usually it was with or without lateral hamstring lengthening. But in this case, it was with the semitendinosus transfer. So the semitendinosus transfer ceased to be a flexor of the knee, and it maintained its hip extensor function. So probably this was one of the causes which actually reduced the anterior tilt in their study. And the limitations of the study is that they had a varied follow-up of cases, and again this study is also retrospective in nature. And though there are many studies which actually mention which have assessed purely the functional outcome, but in this particular study that was not assessed. And they also included the tendo Achilles lengthening and the strayer operation also in this particular procedure. So again, that might have actually affected some kind of the knee kinematics, but that was again not excluded.
Okay. So they support the judicious hamstring lengthening in knee flexion, right?
Yes.
Right. So there is a big rage against hamstring surgeries in Western world and in Australia. So I really don't know um, where is the truth exactly we should be doing or not doing. Samir, what's your take on this?
Yeah, actually, I was there in 2006. So at that time, they had stopped doing Z lengthening for the semi-T. They were doing aponeurotic They would either do aponeurotic semimembranosis and a semitendinosis, or a aponeurotic semimembranosis with a transfer of semi-T. But I was just reading what Paulo has written to us, and then he has mentioned that now he stopped doing semimembranosis aponeurotic lengthening also, and he does only semitendinosis transfer. So naturally, it's going to need some time for the results to come out. But
He leaves
wo-
semi membranosis as such
yes,
without doing it.
he's not doing aponeurotic lengthening of semimembranosis now.
The problem is in our cases, till the time you don't do semi membranosis, so many times the patients, the popliteal angle just doesn't correct. So I really don't know if semitendinosis alone is essential or. Uh, so we'll ask him.
Yeah, we'll ask him tomorrow.
Yeah.
Yeah.
Any takes from anyone else in the group?
Sir, any comment on the sauce release along with hamstring lengthening? Like anterior pelvic tilt is always there. So, and many a times LEs is equivocal or not so positive.
Yes. So there are three situations. In a child who's walking with knee flexion gait, one situation is their hamstring is tight, but knee flexion and hip flexion deformity is less than 30 degrees. In those cases, you can do hamstring lengthening and need not do psoas lengthening, but you can just do exercises and it will become all right. The second situation is that there is a hamstring tightness and hip flexion deformity is more than 30. So in that case, you'll have to do both. And third situation is that there is a anterior pelvic tilt, there is a significant hip flexion deformity, but hamstrings are not tight at all. And here the child is walking with knee flexion because of anterior pelvic tilt. What happens is the ischial tuberosity raises uh, proximally, and it carries with it the hamstring insertion, and you get what is known as apparent knee flexion, which is like apparent equinus. You get apparent knee flexion, and in that case you should not do hamstring lengthening but do only psoas.
Yeah.
But these are simplistic recommendations. I think when it comes to a patient, I think there are many more factors which uh, so one of the problems with releasing psoas is that it takes away the hip flexion power, and hip flexion power is required for clearance. So if you have a high level functioning CP child, one should resist from doing psoas lengthening as much as we resist doing calf lengthening or hamstring lengthening. So if everyone is against all sorts of lengthening, तो लेंदन क्या करने का, रेक्टस ही बचा है फिर. People don't want to lengthen calf, people don't want to lengthen hamstring, people don't want to lengthen psoas for different reasons. And you are left with only one muscle to lengthen, which is not required most of.
Yeah.
I don't know. Yes, Jaideep, bolo. Yeah. Any other sort of on muscle lengthening? Any other take questions? All right, Jaideep, your.
Yeah, yes.
So Jaideep and Varun are from a very difficult femur case. I think they've done it very well. We'll share the images after journal club is over. Yeah, go ahead. तेरा आवाज नहीं आ रहा है, ये निकाल दे.
Hello.
Remove your
Can you hear
microphones
me?
and the connection also you remove.
So this is Varun, correct?
We can't hear anything.
Hello, can you hear?
हाँ अभी ठीक है, हाँ अभी बात.
Yeah. Hold. So this is a very good paper. Does the additional patellar tendon shortening influence the effect of multi-level surgery to correct the flex knee gait in CP? This is the first randomized control trial. So aim of this study is the patellar tendon shortening as a part of ACMLS is effective in reducing the flex knee gait in children with cerebral palsy, and PTS is going to lead the steep knee gait. So patient as a material, this is a randomized control study of 22 children. Age they included 10.5 plus minus 2.6. They included GMFC 1 to level 3. So they have made the two groups. Group 1 ACMLS with patellar tendon shortening. Second group ACMLS with no patellar tendon shortening. So in ACMLS with PTS, 8 children with 16 limb, ACMLS with no patellar tendon shortening, 12 children with 24 limb. They have recorded before and after the surgery, clinical examination, gait analysis, and compare. The result, maximum knee extension improves significantly in the group. Group 1, those who have patient and the patellar tendon shortening, knee extension improved from 37.6 to 11.6. P value is significant. In group 2, this improved from 35.1 to 21.8. The P value is 0.016. Second important finding is P knee flexion decreased significantly in the PTS group. Comparative, there is no change in peak knee flexion in those patients who have not done the patellar tendon shortening. Second, in all the papers just mentioned, there is increase in anterior pelvic tilt after the surgery in both the group, but there is no statistical significant difference. After surgery, knee flexion contraction is improved, popliteal angle is improved, only decreased significantly in ACMLS with patellar tendon shortening group. Here is they have shown the 3D gait analysis preoperatively and postoperatively. Here you can see the knee extension is significantly improved. Those blue is those who have done the patellar tendon shortening, and red is the group who have not done the patellar tendon shortening. Here you can see the anterior pelvic tilt is also increased anterior pelvic tilt in those patients who have done the patellar tendon shortening. The conclusion of this study is that patellar tendon shortening is effective for correction of the knee flex gait and knee flexion contraction, leading to superior trans phase of knee extension. Additional patellar tendon shortening may lead to steep knee gait and higher increase in anterior pelvic tilt. Limitation of this study is very small sample size. This is the first randomized control study investigating the effect of PTS on the flex knee gait. Further investigation should be focused on the effect of rectus fibri transfer or proximal release to avoid the steep knee gait. Paper is open for the discussion. Anybody has any question?
Yeah. So we are going into more and more complications here. It's you correct the knee. Once you correct the knee, you have extension lag. You correct the extension lag by getting patella down, and then you have stiff knee gait. So then you do release of rectus. Moment you release the rectus, what happens is pelvic goes behind. Pelvis will turn behind. Instead of anterior tilting of pelvis, you'll have a posterior tilting of pelvis, and that loosens up the hamstring and creates further issues. So nothing is simple.
So on this paper in the details, out of this, all the patient they did in 6 patients they did the simultaneously rectus femoral transfer. So that patient will give rise to better result comparatively other patients because they have make the 2 groups. But I am still confused. Ideal indication where we do the PTS, because if you over tighten that they will indirectly develop into steep knee gait, anterior pelvic tilt. The secondary give rise after long-term studies show that it further gives rise to crouch, English flexion.
It also gives rise to patella baha, excessive patella baha. So, it's not that simple.
Jaideep, have they mentioned anything about Kushino angle and index and CD index?
No. They are not mentioned in this paper.
I would like to add an interesting thing because when I was in Australia, that time Paulo always used to stage these surgeries. So we never used to do patellar tendon shortening with supracondylar extension osteotomy. So he used to do the supracondylar extension osteotomies with simils and then allow the child to walk and then later on decide whether to do patellar tendon shortening or not. But now I think so the trend is changing towards adding patellar tendon shortening at the same sitting. But now we have read this paper which mentions that it is not that effective. So as sir mentioned,
lot of paper shows that patellar tendon shortening is very effective in crouch, but this paper also and next paper is also contradicted in this paper.
So you discuss the next paper and then we will discuss both of them together.
Does patella lowering improve the crouch gait in cerebral palsy? Here The aim is here to improve the quadriceps function as a means of correcting crouch gait in patient with cerebral palsy. Hypothesis patella lowering into component of the multilevel surgery is beneficial in patient with crouch and patella alta. Here there is a retrospective study, 12 limb in 41 children with CP. Patella lowering was performed without distal femoral extension osteotomy or hamstring release. It's a group and control hamstring lengthening, rectus femoral transam, except the patella lowering as a control group. The propensity score was computed based on the preoperative knee flexion contracture, knee extension lag, minimum knee flexion at mid stance. Clinical and 3D kinematic data were compared in both two groups. Result, the improvement in the minimum knee flexion at a mid-stance was significantly greater with the patella lowering group. The gait deviation index is improved similarly in both the group. Extension lag did not improve in either group. This is important finding. Knee flexion contraction improve only in patella lowering group. Those we have done the patella lowering procedure. Peak knee flexion during the swing phase remain in unchanged group. As comparatively first paper, there the peak knee flexion is increased. Here they are saying is unchanged in both the group. So discussion here. Patella lowering is effective in diminishing the minimum knee flexion at the mid stance in patient with patella alta and crouch. Patella lowering has no adverse effect on gait. This finding cannot be assumed to apply to patient with normal patellar heights. This paper is mentioned only this thing.
Basically, as I found, there are three people type of pathways which are followed. One is that people who do knee flexion correction either with hamstring lengthening and plaster or with epiphysodesis or with osteotomy first, and after it is corrected and patient walks, after at the time of implant removal they will do patellar tendon advancement. The advantage of this strategy is that when you do a soft tissue lowering of the patellar tendon advancement, it is not all that strong. But if you are able to do the same surgery in patient with skeletal maturity, you will do tibial tuberosity transfer, which is much more stronger than patellar tendon advancement. That's one approach. Second approach is to do the distal femoral osteotomy and patellar tendon advancement same time as most of us has been doing. And when you do implant removal, you can do a rectus lengthening or a transfer if required. And there are third group of patients, mainly from Europe. We do all together. They will do um, patellar tendon advancement, knee flexion deformity correction by DEFO, and rectus lengthening all together. So, in fact, if Chasma can comment, we have had some patients where after doing patellar tendon advancement, we have had avulsion of tibial tuberosity in some of the cases because rectus was too tight. And we feel in those patients where rectus is too tight, which is found by gait analysis, if there is a pre-existing stiff knee gait with crouch, then I think we should do all the three together. Chasnal, you want to comment something? Yeah, is she around? I think she has some poor connection, so I don't know if she is able to hear.
No, sir, I just want to ask.
Sir, I could hear you, sir.
Yeah,
There
yeah,
is little connection issue. So
yeah,
yeah.
yeah.
So we had couple of these patients, sir, and Samir said that we need to calculate some of their angles or the Koshimoto's index or whichever particularly we feel is important. And the ones with very high patella alta, sir, probably those we could consider for a on table rectus lengthening along with transfer. So when
So
we
those are not well defined.
transfer the, yeah,
Hmm.
they're not well defined, sir. So I
But if
spoke
there is
to,
an
I think
existing
Novacek is doing
gait,
these procedures, sir. So
hmm.
last time we spoke to Novacek, he said he is doing concomitant lengthening of the rectus and transferring of the patella. And he
Same
said
time.
only the rectus was not attached to patella. So there was a medialis lateralis, which was also
Yeah,
working to
strength is
take
not
the
a problem.
patella down and correct the extension lag. And same time, this only rectus could lengthening could avoid those avulsions of the tuberosity, since they were the ones who propagate these procedures. So probably they have also gone through these problems prior to us, probably. So he's the one who's doing, sir, and he might come up with some article shortly, probably.
So one more problem is rectus is eccentric controller of the knee. So when there is excessive knee flexion in swing phase, rectus controls it. So lengthening of rectus sometimes allows excessive knee flexion, and it reduces the step length. So there are issues which we need to study over a long time. But there will be some patients where rectus lengthening may be required, not all of them. And if required, you can do it at time of implant removal also.
Constantly the rectus is firing, that would be one of the patient to
So
do the
EMG
rectus
would be
lengthening.
EMG would be a good way to know whether. And again, the problem is if the something is firing, instead of, like, if there is a fire, instead of extinguishing the fire, you are doing lengthening procedure.
Yeah, more of it.
You really don't know, are we doing the right thing? Anyways, yeah, your papers, quickly go through the results. You can do all the three together and then we can discuss together.
Yeah, if can stop this. Yeah. Yeah. Am I visible?
Yes, yes.
Yeah. Okay. So basically, I'm going to be presenting three papers. All are from the Gillette group. The first one is the evidence of dysfunction during sit to stand following distal femoral extension osteotomy and patellar tendon advancement in young adults. So in this, basically we know that we do PTA or TT during DFEO to correct knee extensor insufficiency, and we know that they have decent good short-term and long-term gait outcomes. Uh, they have observed that in all their patients they had patella baha at the end of the procedure or follow-up, because in their technique they did a minimum of at least 2.5 centimeters distalization. But in the short term of follow-up of their patients in functional outcome scores, they saw a lot of them showed declining scores in the DFU and PTA group compared to the either DFU or just the PTA group. And they did a lot of musculoskeletal modeling, which showed that the patella positioning, it decreases the quadriceps moment generating ability during increased flexion angles. So their main aim was to study 5 fast sit to standing activities which they made the child do at a long term follow up of more than 8 years and compare between both the groups. They wanted to, their hypothesis was that the DFU and PTA compensate for their patella baha by using their hips more to do these sit to stand activities compared to the other group. So they had 28 patients of DFU PTA and 23 patients in the other group, and all were at least 20 years old and minimum of 8 years above post their surgery or procedure. And all the participants who could perform the task without any assistive device were asked to perform it quickly as possible and were given a 43 centimeter high armless backless bench behind them, and all of kinetic, kinematic and other parameters were seen. Basically they saw that 43% in the first group and 39% in the second group could complete the task, and it was seen that in the patients who couldn't complete the task, they were all lower functioning with weak hip and knee extensors, high GMFCS level, and all had very low FAQ scores regarding to their mobility. The mean time for the non-DFEO group was 14 seconds and 20 seconds for the DFEO PTA group, which showed that it is 3 times slower than a typical developing adult at that age group. The peak knee and hip extensor moment and positive power generated was similar in both groups. The peak negative knee and hip power were larger for the non-DFEO group. Peak moments and powers across the 5 repetitive motions showed stability. There was no group difference in loading of the knee and hip, and the groups utilized their hip extensors approximately twice as much as their knees. So this is one of the charts of the patients which showed good stability in repetitive motions. So non-DFEO patients, they absorbed more power at the hips, contributing to faster times in performance. But the difference did not take into account their motor involvement and ability, which could have led to a larger effect. Most who completed the task tended to be of a lower GMFCS level in the non-DFEO PTA group compared to the DFEO and PTA group. So basically, overall, it states that all these patients have severe patella baha, and it does affect their sit to stand activities and deep flexion activities, but it does not account to how much it will compromise their daily living activities, because they also have hand function to help them. So more future research is warranted to know about patella positioning after our DFEO PTA to improve unaided sit to stand function without compromising any improvements which we achieve in the gait. Should I move on, or hello? The next paper is they are the long-term outcomes of the DFEO PTA from the Gillette group after their original paper. So they wanted to compare the gait parameters which differed between young adults in CP who underwent DFEO PTA and who had other conventional treatments as before. And most of their patients were all above the age 20 and had a minimum of 8 years follow-up post either DFEO PTA or baseline gait analysis in the non-DFEO PTA group. So 34 patients and 30 patients, and they all had gait analysis, physical examination, X-rays, and filled questionnaires. They had a minimum follow-up of 13 years. 13 DFEO PTA patients had a short-term gait analysis between the 9 to 24 months, which they used as an extra analysis point. And some non-DFEO PTA group received other treatments, non-invasive treatment after baseline, but 6 had received some form of treatment before, which they have not mentioned. DFEO and PTA group basically were more severely involved in terms of minimum knee flexion, extensor moment, the amount of contracture, and the amount of patella alta seen. And the non-DFEO group were slightly older in age group comparatively. So what they saw at baseline, that the DFEO PTA group had more knee flexion in mid stance in comparison, which was significant. They gained more extension than the non-DFEO PTA group, uh, which was also significant. The most significant thing to come out in long term, that 37% of children who were operated still had some amount of crouch present at the end of their follow up, and 65% had some form of crouch again in the non DFEO PTA group. The DFEO PTA group, with a short term visit, they saw that there was a loss of 7 degrees in knee extension per visit. And at baseline, the DFEO PTA group had a lower GDI than compared to the non-DFO PTA group. In long term, this improved, though, but overall, it was almost similar between the groups. The DFAO PTA group had greater peak extensor moment when walking without devices. At long term, greater decrease in extensor moment was noted in the DFEO and PTA group. They had better, greater decrease in oxygen consumption. Although, but overall, it was seen that these levels ended up being similar between the groups at the long term follow up. They had less flexion contracture compared to the non DFEO PTA group. Uniarticular hip extensors and plantar flexors were weak in both the groups. Extensor lag improved in long term in both the groups, but there was no statistical significance. At baseline, more DFEO PTA patients had patella alta, whereas in long term, more in the other group had patella alta. So all of their patients in DFEO PTA had patella baha, and they report some of them they did not report any issues in their questionnaire, but some non-DFO PTA group reported some amount of knee pain during sitting and transfers. So basically, this paper says that DFEO and PTA improve stance phase and knee extension and knee flexion contracture, but there is a minor decline in gait for all these patients from short term to long term. The benefits of the surgery, they might not translate into improved activity, participation, or knee pain in early adulthood. There is no change in their GMFCS in the long term, but this paper was a retrospective study and they could not do matching of variables at baseline and at a long term follow up, and they did not have a lot of data was missing. They could not even match with respect to any previous surgeries which these children had, and the sample size was not the largest. And the final paper is the effect of this surgery on muscle lengths. Basically, the study was done on a model simulation to study the effects of this surgery to quantify the change in length, muscle lengths, and also to assess the outcomes of how our wedge apex locations and magnitude uh, cause changes in muscle length and axis. So they used in this model, they modified their previous model to have effects of contacts of the ligament and other constraints. And all knees had a flexion contracture of at least 30 degrees in their model to start off with. For quadriceps, they measured the vastus medialis, and for the hamstrings, they measured the semimembranosus length. So this diagram shows the modeling which they had used, and to replicate crouch, they used at least a flexion contracture of 30 degrees and did the osteotomy and surgery exactly as described by Stout and Novacek. The results were that the osteotomy increases semimembranosus length, vastus medialis length is reduced, the anterior or the and more anterior the apex wedge had a larger effect on the muscle femur and muscle lengths. Rotation, 30 degrees of internal rotation shortened the semimembranosus by 3 millimeters and lengthened the vastus by 2 millimeters. A centimeter change in the superior location of the apex had changes in translation distance by half a centimeter. And more, so basically it said that more proximal the wedge, it necessitated greater translation. 1 centimeter change in anterior location of the apex needed a zero point 0.1 centimeter change in translation. So translation had a larger effect on quadriceps in comparison to the hamstring lengths. Posterior translation of 2.5 centimeters changed the hamstring length by zero point 0.2 centimeters compared to the quadriceps by zero point 0.4 centimeters. So this is the diagram which they used to show us how they played around with the model and to calculate the hams. So basically, they said that whenever we do just an uh, correction without a cuneiform type wedge, there are increased stresses in the hams causes increased tension in the posterior compartment, which can be reduced by the cuneiform wedge. But then again, that leads to further shortening and decreases the effect, quadriceps length, which again needs to be compensated by our PTA, which in their model showed at least 3 centimeter distalization, which is quite high. So this model kind of shows us what their paper already told us, that there is reduced quadriceps length after DFUO, which needs a simultaneous PTA. And there is hamstring stretch during this surgery, which can lead to nerve palsies. So all of these considerations can help us during planning of our DFU and PTA. But end of the day, this is a simulation model based study, and it did not take into other factors of cerebral palsy which come into effect during surgery. Hello.
Yes, sir. Uh, can we go to your second presentation, last slide?
Yeah.
Second presentation, last slide. I mean, previous to this presentation.
Yeah.
Can you repeat and explain this line? Minor decline in gait for the DFU and plus PTA.
So overall, most of these children, uh, from their apex surgery, they had a decline in function. So it's not like it was same as what we had done during the surgery. In long term, all of them had some decrease in movement. So even though but what it is significant that it was less in this group as compared to the non-DFEO group. So there is some amount of recurrence of minimal crouch in long term, even after surgery.
Yes. Okay. Okay. Can we go to the last presentation, last slide? So, induced hamstring stretch can lead to nerve palsy. So it means we'll be making the child or that patient for physical, I mean, physiotherapy for hamstring stretching exercises should be done.
It's not that. So when we do DFEO surgery, we are quite worried about the foot drop because hamstring we are not trying to touch. And if you do a wedge which is triangular and not uniform, it can sometimes lead to increased posterior knee compartment pressure, which can lead to common peroneal nerve palsy. So
Right.
that we need to be wary of when we are doing the surgery.
Is there any? I'm sorry, I want to ask you again. Is there any connection between? Well, can we do anything with physiotherapy? With this point, you explained.
No, I don't think physiotherapy will help in this because we are not changing the length of the nerve. As we correct this, the length of the hamstring increase. So I don't think physiotherapy has anything to do with that.
Okay, thank you. Thank you, sir.
We just be on the next slide. The problem with the translation, so much translation, is that there is a posterior spike,
Yes.
and that needs to be chopped off.
Yes.
So just go back to that last slide, and moment you chop it off, we've done it in several few cases. The contact area between the distal fragment and the proximal fragment becomes a point contact,
Yes.
and then you have problem with stability and union.
So that's why, sir, they say our osteotomy starting level should be as close to the joint as possible, which reduces the amount of translation. So the amount of fragment which we have to cut also reduces accordingly.
Yeah, but again here this will require a special plate. So if you are
Yes.
using a distal femoral plate, that plate is actually meant for femur with physis open.
Yes.
And if you are using that plate, the problem is the number of screws which will have in distal fragment will be very few.
Yes.
And
So
that means we need a newer plate, new design plates.
so most of these centers, they all use the locking blade plate for the distal femur.
Yeah.
And they have not found any problems, and you can go more closer to the physis also with that.
Yeah, absolutely. So the osteotomy, don't go very proximal with the osteotomy. That's the sort of take away from this. More distal you go, biomechanically you are bound to be more sound.
And so the more proximal you go, your wedge has to become larger and more cuneiform, so you end up doing a lot more shortening to correct the translation as well as that.
Right. All right. The only problem, many times more distal you go almost into the notch.
Yes.
And
yeah.
the only good thing is you're getting patella down, further down, so that doesn't come in the way. Yeah.
But sir, as I said in the previous study, they get all of their patella down, and they have Baha in all of their post-op patients, but then they see they have sit to stand problems. So we still don't have a balance in how much, which to improve the gait or to improve the function, and how much is it which will give us a fine balance between these two.
Right. Nice. So Rohan, you want to say something? He's raised his hand.
Yeah, sir, how often do we see patients of cerebral palsy children who require a PTA and not a distal femur extension osteotomy? Because if
very rarely.
Very rarely.
I'll give you an example. So there are patients which we see many times where we have corrected knee flexion deformity through hamstring lengthening and serial plasters, or we have corrected it through a distal femoral osteotomy. And those are the patients where we have not required a rectus procedure. Now we have a patient which we had shown in one of the last CP meetings which Dr. Jory had organized, where Chasnal had presented, where we had done only hamstring lengthening and that patient got near normal gait pattern. So on longer follow-up, that patient does have weakness of quadriceps and stiff knee gait both together. And we'll have to do some action at quadricep level, but it does not require axis correction. So it does not require femoral osteotomy. So many of the patients where, if the patient is able to follow up with you at a much earlier date, they will not have problems of knee alignment, but they'll have problem of extensor mechanism.
So the
One
other,
major part which we have not included in these papers is a effect of foot stabilization and tibial torsion. And I think that will require, a separate journal club by itself to deal with.
so like from all of these papers I've seen, like one way we are proponent of not touching the muscle and doing bony surgery. But again, sometimes we are adding soft tissue surgery with our bony surgery, kind of negating the concept again. So
I'll just see, for every question, no, there is a Hindi film song which is an answer. So there is a Hindi film song called "Ek Sawal Main Karu, Ek Sawal Tum Karo," कि हर सवाल का जवाब ही सवाल हो. I don't know if anyone has heard this song. So which means that in every answer lies a question, which we need to further work upon, and that's how we go ahead and progress. So, I'm sure there are no fixed answers. We are improving, but we have not reached a destination. The journey is still on. And one of the parts of our journey is going to be the webinar tomorrow with Paulo Sandbar, where Samir and Ratna, along with me, we're going to ask him some questions. So if you have any questions after this for him, please send to me on my WhatsApp so I can include them in the program, those questions. Rajiv is asking, is shortening PT better than PT patellar tendon reefing? So I think shortening is better, it's stronger, reefing opens up. So, that is known. So what we'll do is, if there are any further question, otherwise we can close down this webinar. And if you have any question, keep putting on the group. So everyone who's on the group is still on the WhatsApp group. So please keep putting your questions. And if anyone wants to be part of presenting any papers, let me know. And if you have a topic in mind, also let us know so that we can include. What are we doing? Are we next time? What should we do? So we go through December JPO, right? Next time. Is that okay?
Yes.
Next, so it's asking Jaideep, you take out the papers, and then if anyone wants to volunteer for any of the papers, just let me know. This is a platform for everybody. So anyone who wants to review any particular article is absolutely free to. So till that time, stay safe and take care of you and your family. And let's continue this activity even after the lockdown is over. Inshallah. Bye. Take care.
Bye, sir.
Thank you.